Now let's see acute inflammation. Acute inflammation has three major components: dilation of the small vessels leading to an increase in the blood flow, increased permeability of microvasculature enabling the plasma protein and leukocyte to leave the circulation, and emigration of the leukocyte from the macrocirculation, their accumulation in the focus of injury, and activation to eliminate the offending agent. So, what are the components of acute inflammation? First is the dilation of vessels, increasing the blood flow to the area. Second is increased permeability to allow the plasma protein and leukocyte to leave the circulation and reach the site of action. And then emigration of leukocytes and their accumulation to the site of injury and their activation to eliminate the offending agents. When an individual encounters an injurious agent such as infectious microbes or dead cell, phagocytes that reside in all tissue try to eliminate this agent. At the same time, phagocytes and other sentinel cells in the tissue recognize the presence of foreign or abnormal substance and reacts by liberating the cytokines, lipid messengers, and other mediators of inflammation. So, first the phagocytes residing in the tissue try to eliminate the agent, and at the same time phagocytes and other sentinel cells in the tissue recognize the presence of foreign or abnormal substance and react by liberating cytokines, lipid messengers, and other mediators of inflammation. Some of these mediators act on small blood vessels in the vicinity and promotes the efflux of plasma and recruitment of circulating leukocytes to the site where the offending agent is located. Reactions of blood vessel in acute inflammation. The vascular reactions of acute inflammation consists of changes in the blood flow, of blood and permeability of the vessel, both designed to maximize the movement of plasma protein and leukocytes out of the circulation into the site of infection or injury. The escape of fluid, proteins, and blood cells from the vascular system into the interstitial tissue or body cavities is known as exudation. An exudate is an extravascular fluid that has high protein concentration and contains some cellular debris. Its presence implies that there is an increase in permeability of blood vessels triggered by some sort of tissue injury and ongoing inflammatory reactions. In contrast to exudate is a fluid with low protein content, most of which is albumin, little or no cellular material, and low specific gravity. It is essentially an ultrafiltrate of blood plasma that is produced as a result of osmotic and hydrostatic imbalance across the vessel wall. Without an increase in vascular permeability. Edema denotes an excess of fluid in the interstitial tissue or serous cavity. It can either be an exudate or a transudate. Pus, a purulent exudate, is an inflammatory exudate rich in leukocytes, mostly neutrophils, and the debris of dead cells, and in many cases microbes. So what is the difference between exudate, transudate, edema and pus? So exudate is an extravascular fluid which is high protein concentration and contains the cellular debris. Its presence implies the increased permeability of the blood vessel triggered by the injury or inflammation, whereas transudate is a fluid with low protein content and little or no cellular material and low specific gravity, which is an ultrafiltrate of blood plasma that is produced as a result of osmotic and hydrostatic imbalance across the vessel wall without any kind of change in permeability of the vessel, whereas edema denotes to the excess of fluid in the interstitial tissue or serous cavity, which can either be exudate or transudate. Pus is a purulent exudate, is an inflammatory exudate rich in leukocytes, mostly neutrophils, the debris of dead cells, and in many cases microbes. Changes in the vascular flow and caliber. Change in the vascular flow and caliber begin early after the injury and consists of the following. Vasodilation is induced by action of several mediators, notably histamine, and on vascular smooth muscles. It is one of the earliest manifestations of acute inflammation. Vasodilation first involves arterioles and then leads to opening of new capillary bed in the area. The result is increased blood flow, which is the cause of heat and redness, erythema at the site of inflammation. Vasodilation is quickly followed by increased permeability of the microvasculature, with an outpouring of protein-rich fluid in the extravascular tissues. This process is described in detail below. So vasodilation is quickly followed by increased vascular permeability of microvasculature with an outpouring of protein-rich fluid into the extravascular tissue. This process is described in detail below. The loss of fluid and increased vascular diameter leads to slower blood flow and concentration of red cells in small vessels and increased viscosity of blood. This change results in engorgement of small vessels with slowly moving red cells, and the condition is termed as stasis, which is seen as a vascular congestion and localized redness of the involved tissue. As stasis develops, blood leukocytes, principally neutrophils, accumulate along the vascular endothelium. At the same time, endothelial cells are activated by mediators produced at the site of infection and tissue damage and expressed increased level of adhesion molecules. Leukocytes then adhere to the endothelium, and soon afterward they migrate through the vascular wall into the interstitium tissue in a sequence that is described later. Increased vascular permeability, vascular leakage. Several mechanisms are responsible for increased permeability of post-capillary venules, a hallmark of acute inflammation. Contraction of endothelial cells resulting in increased interendothelial space is the most common mechanism of vascular leakage. It is elicited by histamine, bradykinin, leukotrienes, and other chemical mediators. It is called as immediate transient response because it occurs rapidly after exposure to the mediators and is usually short-lived, 15 to 30 minutes. In some form of mild injury, example after burns, irradiation or ultraviolet radiation, and exposure to certain bacterial toxins, vascular leakage begins after a delay of 2 to 12 hours and lasts for several hours or even days. This delay, prolonged leakage, may be caused by contraction of endothelial cells or mild endothelial damage, later appearing. Sunburn is a good example of this type of leakage. Endothelial injury resulting in endothelial cell necrosis and detachment. Direct damage to the endothelial is encountered in several injuries, for example in burns, or is induced by the actions of microbes and microbial toxins that target the actions of microbes and microbial toxin that target the endothelial cells. So vascular endothelial injury resulting in endothelial cell necrosis and detachment. Direct damage to endothelium is encountered in severe injuries, for example in burns, or is induced by action of microbes and microbial toxins that target the endothelial cells. Neutrophils that adhere to the endothelium during inflammation may also injure the endothelial cells and thus amplify the reaction. In most instances, leakage starts immediately after injury and is sustained for several hours until the damaged vessels are thrombosed or repaired. Increased transport of the fluids and proteins called transcytosis through the endothelial cell. This process may involve intracellular channels that may be stimulated by various factors, such as vascular endothelial growth factor VEGF that promotes the vascular leakage. However, the contribution of this process to the vascular permeability of acute inflammation is uncertain. Normally, the vessel lumen contains leukocyte plasma proteins lined by endothelium and the tissue. B is the retraction of endothelial cells, which is induced by histamine and other mediators, rapid and short-lived for minutes, 15 to 30 minutes. Endothelial injury caused by burns, some microbial toxins, rapid, may be long-lived hours to days. Principal mechanisms of increased vascular permeability in inflammation and their features are underlying causes. Although this mechanism of increased vascular permeability, as described separately, all probably contribute in varying degree in response to most stimuli. For example, at different stage of thermal burn, leakage results from chemical mediated endothelial contraction and direct and leukocyte dependent endothelial injury. The vascular leakage induced by this mechanism can cause life-threatening loss of fluid in severely burned patient, because in case of burn, the fluid is already lost due to the injury, and if there also occurs the transudation of the fluid in response to the burns, then there will be excessive loss of the fluid from the circulation. Response of lymphatic vessels and lymph nodes. In addition to blood vessels, lymphatic vessel also participates in acute inflammation. The system of lymphatics and lymph node filters and polices the extravascular fluid. Lymphatics normally drain the small amount of extravascular fluid that has seeped out of capillaries. In inflammation, lymph flow is increased and also helps to drain the edema fluid that accumulates because of increased vascular permeability. In addition to fluid, leukocytes and cell debris as well as microbes may find their way into the lymph. Lymphatic vessels, like blood vessels, proliferate during inflammatory reaction to handle the increased load. The lymphatic may become secondarily inflamed lymphangitis, as may the draining lymph nodes lymphadenitis. Inflamed lymph nodes are often enlarged because of hyperplasia of the lymphoid follicles and increased numbers of lymphocytes and macrophages. This constellation of pathologic changes is termed reactive or inflammatory lymphadenitis. For clinicians, the presence of red streak near a skin wound is a telltale sign of infection in the wound. So, as the flow through the lymph increases, there is increase in the handle load. So, there is secondary inflammation of lymphatics, which is referred as lymphangitis, or made the draining lymph nodes, called as lymphadenitis. Inflamed lymph node may often enlarge and become because of hyperplasia of the lymphoid follicles and increased number of lymphocytes and macrophages. This constellation of pathologic changes is termed as reactive or inflammatory lymphadenitis. For clinicians, the presence of red streak near a skin wound is a telltale sign of infection in the wound. This streak follows the course of lymphatic channels and is diagnosed by lymphangitis. It may be accompanied by painful enlargement of the draining lymph node, indicating lymphadenitis. So key concepts are vascular reactions in acute inflammation. Vasodilation is induced by chemical mediators such as histamine and is the cause of erythema and stasis of blood flow. Increased vascular permeability is induced by histamine, kinin, and other mediators that produce gaps between endothelial cells by direct or leukocyte-induced endothelial injury, or by increased passage of fluids through the endothelium. Increased vascular permeability allows the plasma protein and leukocytes, the mediator of host defense, to enter the site of infection or tissue damage. Fluid leak from blood vessels results in edema. Lymphatic vessels and lymph nodes are also involved in inflammation and often shows redness and swelling. Leukocyte recruitment to sites of inflammation. The change in blood flow and vascular permeability are quickly followed by influx of lymphocytes into the tissue. These leukocytes perform the key function of eliminating the offending agents. The most important leukocyte is typical inflammatory reaction are the one capable of phagocytosis, namely neutrophil and macrophages. This leukocyte ingests and destroys the bacteria and other microbes as well as necrotic tissue and foreign substances. Leukocytes also produce growth factors that aid in repair. A price that is paid for the defensive potency of leukocyte is that when strongly activated, they may induce the tissue damage and prolonged inflammation because the leukocyte products that destroy the microbes and help to clean up necrotic tissues can also injure the normal bystander host tissue. The journey of leukocytes from the vessel lumen to the tissue is a multi-step process that is mediated and controlled by adhesion molecules and cytokines called chemokines. Adhesion molecules and cytokines. This process can be divided into the following phases. In the lumen, margination, rolling and adhesion to endothelium. Vascular endothelium in its normal unactivated state does not bind circulating cell or impede their passage. In inflammation, the endothelium is activated and can bind to leukocyte as a prelude to their exit from the blood vessels. Migration across the endothelium and vessel wall. Migration in the tissue towards the chemotactic stimuli. Leukocyte adhesion to the endothelium. In normally flowing blood in venules, red cells are confined in the central axial column, displacing the leukocytes towards the wall of the vessel. Because the blood flow slows early in inflammation, which was stasis, hemodynamic condition changes, wall shear stress decreases, and more white cells assume a peripheral position along the endothelial surface. This process of leukocyte redistribution is called as margination. Subsequently, Leukocytes adhere transiently to the endothelium, detach and bind again, thus rolling on the vessel wall.